Dear colleagues, I acknowledge Eric Achula and the French network of FAI²R to give me the opportunity to talk about update for ITP in 2022. I will talk about adults only and not children form of the disease. My conflicts of interest. So the first point is one information about American guidelines. As you know, in France, our practice is to systematically perform bone marrow aspiration in ITP after the age of 60 years because we are anxious about the probability of association between thrombocytopenia and MDS. But in fact, the American guidelines is different because in the USA, our colleagues do not perform bone marrow aspirate because they consider that if the patient had a typical ITP, the probability to have an association with MDS is very low. So I think that it's probably a good strategy, and I think that in a next future we will modify PNDS in France because I think that if you have a typical ITP, it's not really necessary to systematically perform bone marrow aspirate. But if your patient doesn't respond to first-line treatment, in this case, it's absolutely necessary to perform bone marrow aspirate or bone marrow biopsy. What about the risk of severe bleeding in ITP? I want to comment this interesting French study. Carbine registry is a prospective registry conducted in France by the CERECAI, and this registry includes adults with a newly diagnosed ITP. And in this study, including more than 300 patients, it has been possible to demonstrate that the only risk factor in multivariate analysis associated with severe bleeding is the exposure to anticoagulants. It's interesting to note that exposure to antiaggregant agents or age higher than 80 is not associated in multivariate analysis with the risk of severe bleeding. So in our practice, if you have a patient with exposure to anticoagulant, it's clear that in this situation it's necessary to keep platelet count higher than 50, but if your patients are treated with antiaggregant, in this situation, it's probably possible to keep the platelet count between 20 or 30 rather than 50. What about the risk of severe bleeding in elderly? In this Carbine registry, this recent study, including more than 500 patients, it's interesting to note that in this 541 patients, more than 40% of patients are aged more than 65. So the first message of this study is that ITP is not a disease for young women as we believed previously, and you can see that it's very frequent to have elderly with ITP. And in this case, if you compare very elderly patients with an age more than 80 years, compare with elderly age between 65 and 79, you can see that in this case, the risk of severe bleeding tends to be more frequent in very elderly patients, and this risk is probably due to that exposure to antiplatelet drugs and anticoagulants is more frequent in very elderly patients. So the first message is very elderly patients is more exposed to anticoagulant and antiplatelet drugs, and in this case, the risk of severe bleeding is more important and is very important in very elderly patients to keep a platelet count higher than 50. What about the risk of thrombosis? It has been suggested that ITP could be a risk factor for thrombosis, but I think that it's not really true because the data in the literature are controversial. But the message is that ITP is not a protection against deep vein thrombosis or arterial thrombosis. And in this study conducted in France and including more than 10,000 patients or administrative data, you can see that the main risk factor for hospitalization for venous thrombosis is an history of VT. And you can see that with an history of VT, the odd ratio for the risk of VT is more than 4. Other factor is older age, more than 75. For arterial thrombosis, the two factors associated with the risk of hospitalization for AT are older age, more than 75, and an history of cardiovascular disease. What about the risk of vaccination against COVID-19 in patients with ITP? It's a real question because most patients with autoimmune disease are anxious with the vaccination and with the risk of exacerbation of their disease after vaccination. What about for COVID-19 vaccination? In American experience reported by Dave Kuter, in 52 chronic ITP patients followed after vaccination and in a large majority of patients with mRNA vaccination, you can see that Dave Kuter observed 12% of exacerbation of ITP, and on these patients, Dave Kuter used corticosteroids and or IVIG to treat this exacerbation with success, and only 2 patients are on active treatment after the end of the study. In France, we reported our experience in 92 patients, and we found similar results, because you can see that in our patients after immunization we observed in almost 10% of patients an exacerbation of the disease and requiring a transient treatment with steroids. But the message is that first, the exacerbation is very short, very transient, with no severe bleeding, and with a short course of steroids. In almost all the patients, it was possible to cure this short exacerbation of ITP. And in only 1 patient among this group of 92 patients, it has been necessary to keep a treatment for ITP for a long period. So the first message is vaccination against SARS-CoV-2 is not contraindicated in patients with ITP. It's cautious to control platelet count in the day following the immunization, and in case of very low platelet count with bleeding, it's logical to propose a short course of steroids. I would like to comment this very interesting study recently published by Nikki Cooper. It was an exploratory cross-sectional survey, and the goal of this study was to study the impact of ITP and the perception of ITP by the patients and by the physicians. So more than 500 patients received a questionnaire, and almost 500 of physicians received the same questionnaire. And it's very interesting to see that for the patient on the left side of the slide, the more important information is that patients are anxious by the fatigue, by the unstable platelet count, by the depression, and in contrast, you can see that the perception of the physician, the main information for the physician in the risk of bleeding. So you can see that the perception of the disease is absolutely different between patients and physicians. And as physicians, you must take into account these results, because when you treat a patient, you must take into account the anxiety of the patients, the fatigue, the depression, and the message is that for the same platelet count, your treatment will be different between a patient who exhibited fatigue, who are anxious about unstable platelet count or who are depressed, and patients with no fatigue and no problem with the disease. And in some cases, for example, a platelet count of 10,000, you will propose a treatment, and with the same platelet count, you can keep the patients without treatment if the patient had no fatigue, no depression, and no real question about his disease. What about update of the treatment of ITP? The first point is dexamethasone. It has been demonstrated in several controlled prospective studies that if you compare dexamethasone and oral prednisone or oral prednisolone, it has been clearly demonstrated that dexamethasone has a more rapid action with a more rapid response in the patients. In contrast, for the long-term response, there is no difference between dexamethasone and prednisone. So this absence of long-term response is a new proof that steroids does not modify the natural history of ITP. So you must give a short course of steroids. But if your patients are admitted in a hospital for severe thrombocytopenia with bleeding, in this case, after these studies, it is logical to propose dexamethasone rather than a prednisone in patients admitted in hospital. For patients who are treated outside, I'm not sure that dexamethasone is more effective than prednisone, because in this case, the rapidity of action is less interesting. What about Rituximab? As you know, we used Rituximab. We are using Rituximab for more than 10 years in ITP, and it has been clearly demonstrated that Rituximab is an effective treatment, but unfortunately, the long-term response of Rituximab is relatively modest. And for example, in the prospective registry conducted in France, including almost 250 adults, you can see that 5 years after the first course of Rituximab, the long-term response is about 30%. So 1/3 of patients, it's not so bad, but it's not so good. So the question is, how can we obtain better long-term response with Rituximab? The first option is to give repeated infusions of Rituximab. But unfortunately, we have only few data. In the French prospective registry, about 40 patients were treated with repeated infusion of Rituximab, and we observed that in case of initial response after the first course of Rituximab, in more than 90% of patients, you will obtain a new response with Rituximab, and interestingly, in more than half of the cases, the duration of response of the second course was increased. But we have no clear visibility about the safety of this repeated Rituximab infusion. So our practice today is to avoid to give repeated infusion of Rituximab because we have other therapeutic option in ITP. Other option is to associate Rituximab with other treatment. You can associate Rituximab with dexamethasone, and there is at the present time a multi-center international prospective study conducted in Europe, and France is participating to this study, but we have no results. Other option is to associate Rituximab with belimumab, an monoclonal antibody directed against BAFF, because the translational studies conducted by Mathieu Maevas demonstrated that in patients treated with Rituximab in ITP, there is an overexpression of a cytokine, BAFF, and as you know, we have a monoclonal antibody directed against BAFF. So in a first phase 2b trial, Mathieu Maevas treated 15 adults with ITP with Rituximab associated with 4 infusions of belimumab. And interestingly, Mathieu Maevas observed 1 year after 80% of response. It's clear that it's better than that you can hope with Rituximab alone based on historical data. So in view of these very promising results, an international multi-center study comparing Rituximab alone and Rituximab and Belimumab is in process in Europe. What about TPO mimetics? You know that we have two TPO mimetics available in France, Ramiplostim and L-Thrombopag. In Europe, in some countries, Avatrombopag is also available, but unfortunately, French authority refused to give a license for Avatrombopag in France. So, several points about TPO mimetics 10 years after their availability in Europe. The first point is that it's possible to switch because it has been clearly demonstrated that when you fail to respond to one of the two available TPO mimetics, if you take the other TPO mimetics, you have more than 50% of chance to obtain a response. So it's really a good strategy to switch in case of absence of response with one of them, one of the TPO mimetics. The second point is that it has been a surprise that it's possible to obtain a sustained response after stopping TPO mimetics in a patient who had a complete response with TPO mimetics. We have no clear explanation for this fact. Maybe it can be associated with a restoration of Treg cells, but we are not sure. But in practice, if you have a patient with a good response to TPO mimetics, it appears logical to slowly decrease the dose of TPO mimetics, and maybe your patients will have a sustained response without treatment during the follow-up. Other question with TPO mimetics is when we must give this treatment. At the present time, this treatment is reserved for patients with persistent or chronic ITP, but one option could be to give TPO mimetics in newly diagnosed ITP, and some colleagues test TPO mimetics as a first-line treatment and associated with dexamethasone. And in this open, prospective, uncontrolled study, the colleagues observed with a short course of L-Thrombopag, only 2 weeks, and a course of dexamethasone, that after 6 and 12 months, about 50% of patients are in remission of their ITP. So it's interesting, but unfortunately, in absence of control group, it's impossible to be sure that this good response at 1 year is really due to the association of L-Thrombopag and dexamethasone as first-line treatment. So I think that it's absolutely necessary to have control study before being sure that it's the best option for a newly diagnosed ITP. Other information about TPO mimetics is what about TPO mimetics in elderly? And I report this interesting observational retrospective study conducted by Italian colleagues. They report almost 400 ITP patients treated with TPO mimetics, and these patients were considered as elderly because they are aged more than 60 years. It's not a good news for me to see that after 60 years you are considered as elderly, but it's a fact. So what are the message? The first message is that they observed 66% of sustained response. So it's very good. It's exactly the same compared with younger patients. The second information is that in absence of response with one of the two available TPO mimetics, in case of switch, Italian colleagues in elderly observed more than 80% of response. So it's very, very, very useful, a good strategy to switch in absence of response with one of the two TPO mimetics. The third information is that if you have a complete response with TPO mimetics and you decide you decided to stop TP mimetics. In more than 10% of patients, Italian colleagues observed a sustained response after stopping TP mimetics. And the last point is important, is that in 10% of patients, they observed thrombosis, major thrombosis with 3 fatal thrombosis. This association with increased risk of thrombosis in elderly treated with TPO mimetics has been already reported in a small study with L-Thrombopag or Romiplostim. So the message is that if you decide to use TPO mimetics in elderly, you must use this treatment with a cautious if the patient has an history of deep vein thrombosis before. And in this case, I think that it probably caution to use other therapeutic option rather than TPO mimetics. What about immunosuppressant? At the present time, in international consensus, in the French guidelines, PNDS, immunosuppressants are reserved for refractory patients. But in the UK, 3 years ago, some experts proposed MMF, mycophenolate mofetil, as a second-line treatment for ITP. And more recently, a prospective control study was conducted in the UK, and this prospective study compared glucocorticoid alone versus MMF combined with glucocorticoid in newly diagnosed ITP. And it's interesting to see that after 1 and 2 years, the probability of response in the group of patients treated with MMF was better compared with the patients treated with steroids alone. However, unfortunately, we are not aware about the number of patients who were able to stop MMF after response. And other points, we have no clear visibility for the quantity of steroids received by the patients in the two groups. And the third point is that it has been reported by Charlotte Bradbury that in the group of patients treated with MMF, the quality of life was worse compared with the group of patients treated with steroid alone. So to conclude, I think that this study is very, very interesting, but unfortunately, I think that after this study, it's impossible to propose to give MMF as first-line treatment, and I think that other studies are necessary to confirm these results before to change our practice or strategy for the treatment of ITP. And I think that to date, it's logical to continue to use steroids alone as first-line treatment for ITP. What about splenectomy? 2 points. The first point is that it has been recently demonstrated by Italian and French groups that splenectomy is a risk factor for thrombosis. In our experience, for patients splenectomized with more than 10 years of follow-up, you can see that the risk to develop VTE is 10%, and this risk is independent of the pattern of response of splenectomy. So we observed VTE in patients who responded to splenectomy and also in patients who failed to respond to splenectomy. So this risk of VTE should be taken into account. Other information about splenectomy is that in this French study, we recently studied the results of splenectomy for the patients splenectomized after 2010, and the question is that, is it possible to obtain a good response to splenectomy in a patient who are multi-refractory to several therapeutic lines before being splenectomized? In other words, if you have a patient who failed to respond to Rituximab and the 2 TPO mimetics, is it possible to observe a good results of splenectomy in these multi-refractory patients? And the answer is clearly yes, because you can see that in this group of patients who failed to respond to TPO-mimetics and Rituximab, the probability of response to splenectomy was 50%. Other interesting results of this study is that if you fail to respond to TPO-mimetics before splenectomy, if you fail to respond to splenectomy, you have the possibility to give a new course of TPO-mimetics, and interestingly, some patients who fail to respond to TPO-mimetics before splenectomy can respond to TPO-mimetics after splenectomy. This pattern of response has been already demonstrated for steroids. I will finish my talk about the emerging treatments. On this slide, you can see the pathogenesis of ITP and the different sites of drug actions. I encourage you to read this very good article published by Sylvain Audia, and you can see all the sites of action and all the therapeutic options. For example, you can block macrophages with steroids, with BTK inhibitors. You can increase the production of platelets by bone marrow with TPO-mimetics. You can modulate the cooperation between T and B cells. So the first possibility is to associate different treatments with the objective to have action on different sites. And I report the experience of French experience in patients who are multi-refractory to several medical treatments. In this case, for patients refractory to splenectomy, refractory to the two TPO-mimetics, and refractory to Rituximab, if you continue TPO-mimetics that was not active as monotherapy, but you associate the TPO-mimetics with immunosuppressant, in this case we have 70% of chance to obtain a response. So the first option is to associate the drugs. Other interests of the better knowledge of the pathogenesis of ITP is the development of new drugs. And for example, we have now available in France and in Europe fostamatinib. Fostamatinib is an anti-SIK. Fostamatinib is a tyrosine kinase. This tyrosine kinase inhibits the transduction, the signal transduction after the fixation of antibody on the macrophages by Fc gamma receptor. And fostamatinib is useful, and it's possible to use this treatment now in France. And on this slide, you have a not limited list of emerging therapies. You can use anti-CD38 with the objective to block plasmocyte. You can use rilzabrutinib, a BTK inhibitor. You can use, as mentioned, fostamatinib. You can use anti-FCR, and you can use a complement inhibitor. And you can see that in this preliminary study, including patients with very severe ITP, in some study you can see that the patient failed to respond to 6 therapeutic line, and with anti-CD38 we observe 60% of chance of response. And I just comment the results of rilzabrutinib reported by Dave Kuter in New England Journal of Medicine recently, and you can see that in this study, including 60 patients, and you can see that these 60 patients are refractory to 3 previous treatments, and majority of patients failed to respond to TPO-mimetics, majority of patients failed to respond to Rituximab, a quarter of these patients failed to respond to splenectomy, and you can see that with rilzabrutinib, Dave Kuter observed a primary endpoint platelet, stable platelet higher than 50 in 40% of patients with no grade 3 or 4 side effect. So my feeling is that to date we have a very, very high possibility for treating ITP. So as a summary, on this slide you can see the treatment of ITP 20 years ago. Steroid, IVIG, splenectomy, and more recently Rituximab and TPO mimetics, initially reserved for patients who failed to respond to splenectomy. But as you know, now it's clear that all the groups prefer to use Rituximab and TPO mimetics before proposing splenectomy for a patient. And it's clear that today a large majority of patients prefer to be treated with Rituximab or TPO mimetics rather than to be splenectomized. And you can see that at the present time we have other possibility. What about MMF? Is it a good strategy to give MMF as a first-line treatment? I commented dexamethasone. It's clear that for a patient admitted in hospital, dexamethasone could be used as first-line treatment. What about Rituximab before TPO mimetics or TPO mimetics before Rituximab? Should be associate Rituximab with dexamethasone or anti-BAF. So we have a lot of work for the following years. And I will acknowledge my group, Marc Michel, Mathieu Maevas, and all the Henri Mondor team. The Serekai, you can see on this French map all the constitutive reference centers and competence centers, and high knowledge surveillance, Marie Network, and OCITO and AMAPT, Association of Patients with a very, very good cooperation in the field of ITP. Thank you very much for your attention.